Hi, PE 111 class. First, I want to say thank you for bearing with us in this different time, I guess I should say. You guys have all completed your exam 2 last Wednesday, the 23rd, and this week we're going to be going over more of the upper extremity. I want to thank you also for, like I said, bearing with us. Please keep in mind I am newer to this technology or recording. I'm not very well at the editing, but we will give it a go. With that, today we're going to go over chapter 16, which consists of the elbow. So just like with all of our other pathologies that we go over, we're going to have kind of a similar overview in that we want to talk a little bit about the clinical anatomy and expand more what we learned in 108 and or if you've already been in the anatomy class. We'll talk about the evaluation of the elbow, any of the specific special tests, and different pathologies that can and do occur with the elbow. And then also what's going to be different about an on-the-field evaluation as opposed to in the clinic or on the sideline evaluation. So right now I want you to kind of think back a little bit from your PE 108 days and try and figure out what are some of the different pathologies that we can and do come across, specifically talking about the elbow. All right, and with that, hopefully you came across things like a fracture of any of the bones of the elbow, dislocation of the elbow, sprains, strains, bursitis, and those are some of the things that we'll go through. But first, some of the video compilation for different elbow injuries.
Ready, set, go.
Oh shit.
Sorry about the language.
Oh, just do it, yeah.
He's jumping, come on, Laura. Oh my fuck.
Are you okay?
Come on! Come on! Come on!
Snap your arm.
Keep your elbow down! Snap your arm! Oh,
Did you?
This is so intense from both men. Magnus turning that wrist over again. Oh my goodness!
And go!
Alrighty, and with that one you saw a lot of radius and ulna fractures. Here is a dislocation, and I think every single time I've worked a wrestling tournament, I've come across at least one of these elbow dislocations.
Pull him into you! Come on, off your back, Yuri! Fight it!
I'm gonna go back and watch. Radiograph of normal elbow and his dislocated.
Come on, off your back, Yuri! Fight it!
Okay, and that was a posterior dislocation. And with the elbow dislocation, the forearm is displaced posterior or posterior laterally about 90% of cases. So it's most common for a posterior dislocation of the elbow. And then I would be remiss if I didn't add some baseball, and this one is specifically looking at potentially UCLs, or you guys might have heard Tommy John surgery. Or some of the cases, there might even be a fracture in here.
We'll have 3 men on. This one almost gets Reyes. What's going Lackey?
Uh-oh.
That does not look good at all.
Uh-oh.
Through the pitch and then just had the arm slump on him. And in obvious pain. So John Lackey pitches into the 5th inning. And the way he is walking off does not look good at all.
No, it's a shame. Trying to snap off a breaking ball, and immediately you see Lackey in pain right as soon as he released the baseball.
Here's the set. The 3-2 pitch, a wild pitch back to the screen.
This one I think was a fracture.
From third is Alicea. It's ball 4 and Saunders is hurt. A wild pitch because something in his arm snapped. Saunders down on the field writhing in pain. That ball flew out of his hand and went way wide of the plate to the backstop. Jamie Reed, the trainer, out there. John Flaherty is holding Tony Saunders' right fist. It is clenched. And the Devil Rays have another ugly scene here at Tropicana Field.
To repair torn ligaments in his left elbow. And as he let that pitch go, the arm appeared to snap as well. As we took a look on the replay, and it appeared his arm was hanging limp. His right hand now resting on the wrist area of his left hand, and the fans giving him a warm round of applause and support.
Fouled. Instantly I felt very, very sharp pain, and I was down for the count. I've never been taken down on the ground as hard as last night. It felt like my elbow exploded. The way it felt, and I threw it, and when it re-pulled back, it was straight numb. And then maybe 40 seconds after, when I felt it, started throbbing. And for a minute, I didn't know where the pain was coming from. But when I went to grab my elbow, it was loud. It was disgusting. If Gerald heard it, it was pretty loud. So, like I said, I've gone through some stuff with ligament stuff too already, and it's just. What's the first thing that crosses your mind? My career is ended.
He's got an interesting way to grip the bat when he is at the plate. His top hand actually overlays over his bottom hand. I think Ramon is hurt.
Yeah, he sure is. You can see him throw his glove in disgust, but he threw that last pitch, and boy, this is a tough scene here. He knows something is seriously wrong, and now the assistant trainer, Mike Prosted, is up. Felt it in his elbow. Yeah, you never like to see that. So Ramon Ortiz will leave the ball game with an apparent elbow injury.
Whoa!
Uh-oh.
No.
Oh, no. Oh, no.
So it's disheartening anytime anybody gets injured. It's apparent when it's bigger Division I universities or in the professionals, in that people, you're being televised. You don't really have the, I guess, necessity or niceness of not being able to be on TV, and everybody can see your pain and anguish for all to see. All right, and now getting back to our clinical anatomy. So this slide right here, we're looking at the distal end of the humerus, and some kind of highlight marks that we need to talk about is the medial and lateral epicondyle. As far as, that's not working. Okay, the medial and lateral epicondyle. Okay, the trochlear, which is right in the kind of center aspect on the most distal part of the humerus. You've got the radial fossa that the radius is going to go inside, and the coronoid fossa. So each of these are going to be important when we're being able to palpate our patients. And then going just distally, or I guess down into the forearm, you've got a lot more of that bony anatomy that we're talking about. Okay, so the elbow is actually a hinge joint, flexion and extension, where it flexes and extends. We're going to talk about range of motion and everything in a little bit. The forearm, on the other hand, is actually going to be, the radius and ulna are a syndesmotic joint where we end up pronate and supinate. Let's see if I can go. Okay, so before in class where we talked about hold your hands out in front of you, if your hands are up like you're cupping a bowl of soup, that is supination. When you're pouring the soup out, that's pronation. So supination, pronation, and that's happening at the radial ulnar joint. The ulna has an establishing roll, which the radius is articulated in a way that allows it to roll over the ulna, moving the hand from supination or external rotation to pronation or internal rotation. The two bones of the forearm are the radius, which is lateral, and the ulna, which is medial. Remember when we were talking about finding the radial pulse? It was on the thumb side. That's the radial side. Okay. Also talking about the bony anatomy. Up at top is the olecranon process, where that is where it articulates in the olecranon fossa. When we completely extend our arms, it should be at 0 degrees, where it's in a flat line. Some people have a little bit more hyperextension than others, and we'll talk about that fairly quickly. The radius, the head of the radius has a concave top that articulates with the capitulum of the humerus. It also articulates with the radial notch of the ulna. The neck of the radius is a narrow portion of the head of the radius to the shaft of the radius. The shaft widens as it gets closer towards the wrist, and the radial tuberosity is distal to the neck of the radius. The distal radiostyloid process articulates with the wrist. And then on the other aspect, the ulna. The proximal end of the ulna has two large projections. The olecranon is on the posterior surface, and the coronoid process is on the anterior surface. The space between the two projections is called the trochlear notch. The trochleus of the humerus fits into the trochlear notch. Okay, and over here, this is what I was talking about as far as the elbow. It does flexion and extension. So when we're completely straight, it should be in a neutral position where it is 0 degrees. And flexion, the most somebody can flex their elbow is about 145 to 155 degrees. And what's limiting that flexion is soft tissue. So usually your bicep and the muscles of your forearm are touching and don't allow for any more flexion than can be had. Okay, so that's one of the articulations, the humeral ulnar joint, flexion and extension. Humeral radial joint, again, flexion and extension, but there's the possibility to pronate and supinate when we're talking about the proximal and distal radial ulnar joints. It's that part on the forearm is a syndesmotic joint. Okay, so we've already gone over the bones. Now let's talk about the ligaments. Okay, remember ligaments attach bone to bone, and when a ligament is stretched or torn, it's called a sprain. And we can have first, second, or third degree sprains. So right here, we're looking specifically at the ulna, so the medial aspect of the elbow. Up top, you've got the humerus, and then in the forearm, you have the ulna, which is kind of closer to us, and the radius. And then those three ligaments right there actually are probably what you have heard or known called the UCL, ulnar collateral ligament. But what's important for you guys to note is there's actually three different bundles, okay? There is the anterior bundle right here, a posterior bundle, and then a transverse bundle, okay? So when we're hearing of baseball athletes having to have the Tommy John surgery, most frequently that's in reference to the anterior bundle of the ulnar collateral ligament, okay? On the other side, we have the radial collateral ligament and the interosseous membrane in between both the radius and the ulna. Okay. Now getting to more of the muscles. On the left, we have an anterior aspect of the forearm, and on the right, it's the posterior aspect. Okay, so on the left, we have a lot of the muscles that are responsible for extension. Okay, it's bringing the wrist back. Okay, we've got our supinator right here. So that's one of the muscles that's responsible for supinating. And then we've got pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. Okay, and then on the other aspect, looking at the extensors and pronator groups. I have no idea why that just did that. Okay. And in a slide or two, I've got another easy way to help you guys remember some of those muscles. Okay, so when going to the clinical anatomy, one thing we're always needing to be cognizant of is nerves and bursa. I've told you guys before, my team physician is okay with me reducing any dislocations as long as I'm comfortable with it. I've never done an elbow, and I, am not planning on practicing on anybody else's kids. So if I came across a dislocated elbow, I'm going to splint them, check CSM, and get them to the ER where they can take an x-ray, make sure there's nothing in the way, and then reduce it properly. But we need to be aware of the nerves. Okay, so you've got a median nerve, an ulnar nerve, and a radial nerve. Okay, you guys are probably pretty familiar with the ulnar nerve in that when you hit your elbow in a funny way, or maybe mom or dad tells you that, you hit your funny bone. What you're actually doing is hitting that ulnar nerve, which is on the posterior medial aspect of the elbow, and normally will shoot some zinging or numbness and tingling down to your ring finger and your pinky finger. Okay, that's the ulnar nerve, so it's on the medial aspect. The radial nerve is more superficial. It's part of the superficial branch. And it's on the lateral aspect. And then the median nerve is kind of right down the center. And then bursa, we can have what's called olecranon bursitis, and it just depends on where it's at, if it's the subcutaneous or the subtendinosus. And I have a picture later on, but basically what that feels like, it's going to limit their flexion and extension just because they have a lot of swelling, and it really does look and feel like a water balloon that you can kind of just tap. Okay, so with our clinical evaluation of the elbow and forearm, it's really important to know what's going on currently and if they have any past history. So it's pretty prevalent in baseball and tennis, where they're having elbow issues. And we want to see what the past history was. Is it only when they're in season? Is it stemming from the neck? Maybe they slept on it wrong or was in an MVA, motor vehicle accident, and figuring out from there. Do they have any type of vascular or neurological issues or conditions that might hinder the strength on that side or that elbow? And then currently, what is the current presentation of their injury? What was the mechanism of injury? One of the things I ask, especially our pitchers, is were they working on mechanics? Are they working on, and then what type of pitch are they working on? Is it curve? Is it drop? Whatever the case may be. And then I can also go and talk with a pitching coach and kind of help identify maybe what they were trying to do, so I can be able to adequately figure out what's going on. Were there any associated sounds or sensations? So in the baseball video, one of the pitchers said that the catcher could hear it pop. Okay, sometimes it does make a loud audible pop, whether it's that ligament tearing or if it's a fracture. Okay, so inspection. Everything ideally should be equal and bilateral, but take it with a grain of salt, because if they're a unilateral sport like a pitcher, they're going to be stronger and probably have more muscles on that dominant side than on the non-dominant side. So we're looking at functional observation. How are they walking? Is it, uniform, or does something kind of stand out where they're not intentionally moving one side? Looking at their structures. there's a thing called the carrying angle, and that's what's showing here in the picture, where the mid-sagittal line is going straight down the back, and then on the left it's showing what normal is for males, and on the right what normal is for females. And what that's doing is telling us what the carrying angle is for both males and females, whether their angle at the elbow is more steep than the other. Okay, so the angle formed by the long axis of the humerus and ulna are known as the carrying angle. The typical carrying angle ranges from 13 to 16 degrees of valgus in women. So on the right hand side, that's 13 to 16 degrees in women, and for men it's a little less, with 11 to 14 degrees in men. And when we're talking about that valgus, remember L, there's an L in valgus, so that's applying lateral pressure, and it's assessing the integrity of the medial structure. Okay. It's also important to note that we have a cubital fossa. So in the most anterior aspect of the elbow, in that center, you have what separates, or I guess what kind of outlines the cubital fossa is going to be the brachioradialis muscle and the pronator teres muscle, and then right along that joint line of the elbow joint. In there, what's important is all of the nerves and arteries. Okay, so there's the radial artery, brachial artery, and ulnar artery, as well as the median and musculocutaneous nerves. Okay, so you can understand how if there was a dislocation or a fracture right there, that we would want to make sure that we're reducing it properly and not pinching or hindering any of the nerves or artery. So the cubital fossa is a triangular area demarcated by the brachioradialis, the pronator teres, and looking at the different divisions of the arteries and nerves that go through this fossa. Okay, so I've talked about range of motion. Range of motion with the elbow, you should have 0 degrees. On this case, this one has more than 0 degrees, so it looks like they can hyperextend. Okay, this is called cubital recurvatum. So you might have remembered a week or two ago when we went over the knee, and we went over knock-kneed, bow-legged, and recurvatum. The recurvatum, just like with the knee, in the elbow, it's cubital recurvatum. Okay. And then this is what I was talking about with the bursitis. This is a picture from your guys' book, and at this angle you can see it where it's very apparent right here, but if somebody were to touch it, it would kind of wiggle just like a water balloon. Okay. It doesn't cause them a ton of pain. It does limit them on their extension and flexion, which sometimes is irritating, especially for those athletes that need that range of motion in order to compete. All right, getting down to more of the musculature. So on the anterior surface, number 2, in this little square, is the cubital fossa, and you already saw that up close. Number 1, you've got the biceps brachii, and down at the elbow, there's only one attachment, where approximately in the shoulder, there's 2. There's the long head and the short head of the biceps. So when we're talking about biceps tendinitis, it's important to note that it's either in the shoulder or in the elbow. Okay. Number 3 on the top aspect is the brachioradialis, which is a 2-joint muscle. Then we also have the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. Okay, and this is what I was talking about. It's going to make it a little bit more easy for you guys to kind of remember. So this is looking at the superficial muscles of the flexor of the forearm. So if you were to go ahead and place your hand on top of the forearm, where your thumb's at, that's the pronator teres. where your index finger is the flexor carpi radialis, then the middle finger is palmaris longus, and the ring finger is flexor carpi ulnaris. Okay, so this is one that I had to kind of learn with the visual to kind of differentiate where each of those muscles are. Okay, so this is looking at what the bony landmark would be, looking specifically at that medial epicondyle, looking at the UCL. So it's important to know which bundle of the UCL that you guys are palpating and looking at, whether it's the anterior, posterior, or transverse band. It's easier, well, in this particular picture, they have the elbow flexed at 90 degrees to be able to differentiate. You can also do it, obviously, with it extended, and that might help also. Okay. On the lateral structures, we've got our lateral epicondyle and the radial head. Looking at the radial collateral ligament, and the kind of nice thing there is you don't have the 3 different bundles, okay? But you do have the annular ligament and the lateral ulnar collateral ligament. Okay. Extension, or the extensors of the elbow and forearm. So when your elbow is completely extended, it's the olecranon process and the olecranon fossa that keep it from extending even more. Some people have that genu recurvatum or that cubital recurvatum. On the extensors that are responsible for bringing the hand back or posteriorly if you're in anatomical position, this is a good way to kind of differentiate each of those different muscles. Okay, all that, and that was just the anatomy, right? So clinical examination of the elbow. First, when we're doing range of motion, we want to do active, where they're moving it themselves. So you can kind of do the Simon Says, okay, go ahead and do this. Flex your elbow, extend, pronate, supinate. So we have them actively do it. Then me, as the clinician, would tell them to relax, and then I'm putting them into flexion, extension, pronation, and supination. And then finally, I would go against resistance. Okay, these didn't go over as much as I wanted to. Sorry guys. Just showing you passive range of motion where they're not moving it at all. When we're using our hand placement, I like having my hand on the posterior aspect of the elbow because you can kind of feel if there's any crepitus, any crunching, or if it feels like there's a tendon that rolls over a process. And then when we're doing pronation and supination, it's nice to be able to have your hand at the wrist to help pronate and supinate and see what that full range of motion is. Okay, so explaining the different end feels. Okay, and this is where it's a little bit harder to explain online, and I would like to be able to be there, but for the capsular pattern for the ulnar humeral and radiohumeral joint, so basically the elbow where the humerus and the radius and the ulna all attach, we're looking at that is flexion and extension. Extension, you're going to have a hard end feel. That hard end feel is because the fossa and the olecranon fossa and olecranon process are hitting each other, so it's a bony end feel. It's hard. When we flex, it's going to be a soft end feel. And remember I said usually it's about 0 degrees extension to about 135, 145 flexion. And it's going to be a soft end feel because it has your biceps and your forearm that hit each other. So it's restricted due to soft tissue. Now those with maybe big guns and big biceps might have less flexion than others, and that's just because the girth of their bicep. Okay. Elbow, when we're talking about the radio-ulnar joints, looking specifically for supination and pronation, those stereotypically are going to both be firm, okay? And what that is the bones are rolling over one another, and the firmness is going to be either the ligaments or the muscles that are keeping them in place. So when we were watching that arm wrestling and different movement, people were breaking the radius and ulna just because with that pronation and supination, those muscles didn't have anywhere to go or to give. It's the same thing, sorry about that. And then joint stability test. So when we're looking at assessing the integrity of the elbow joint, really we're doing lateral and medial and lateral stress tests. So we've already learned these as valgus and varus, okay? The valgus and varus stress tests. So, for example, this next slide is a valgus test. Remember, there's an L in there. So we are on that lateral epicondyle and putting a medial pressure on the person's elbow, and we're assessing the integrity of that UCL. Okay, it's important to note when we're doing these valgus and varus stress tests, we do not want to do them at 0 degrees. Anybody know why that might be? Okay, when we're doing the valgus and varus, we want to make sure that it's not at 0 degrees, because if we're in 0 degrees, that's probably the most stable position that joint can be in, and it's kind of being protected by the joint capsule. So you do want to flex their elbow to about 25 degrees when you're doing both the valgus and varus stress tests. On this one, the valgus stress test is assessing the integrity of the UCL, specifically the anterior bundle of the UCL. Okay, and the next one, the varus stress test. Now we're on that medial epicondyle and applying lateral pressure to assess the integrity of the lateral collateral ligament. And again, we're at 25 degrees when we're doing each of these stress tests. Okay, for the clinical examination of the elbow and forearm, we would do this with an upper quarter screen, and if and when we come back, that's one of the things we're going to do in lab. Just note that when I've talked about the either upper or lower quarter screen, we're talking about myotomes, myo meaning muscle, so if they can move in a certain direction, dermatomes, derm meaning skin, so this sensation on their skin if it feels equal and bilateral throughout, and then reflexes. So you've got myotomes, dermatomes, and reflexes. So if something doesn't feel the same, or if they're not able to move the muscle in a certain way, that would make me think, oh, it's connected to whatever particular nerve that innervates that muscle, and then I might be able to go back and look up in the cervical spine and see if there's any issues there, because we want to make sure we're checking the whole entire kinetic chain. Okay. Now we're getting into the different pathologies that are related to each of these special tests. Okay, so elbow dislocations. We already saw that wrestler earlier on. Okay, and again, 90% of elbow dislocations are where the radius and ulna are going posteriorly or posterior laterally. Okay. So there's usually an axial force through the forearm with the elbow flexed. So they're not completely locked out. Like I said, it happens very frequently in wrestling. One time I even had a patient who I went out there and he's like, my shoulder, my shoulder, my shoulder. I'm like, are you sure? Because it's your elbow that's dislocated. Okay. So 90% posterior lateral. And then these, I wanted to keep these in here. We're not going to go too much into it, but these are the different tables that are in each of your guys' books. This one's specifically talking about elbow dislocations. Okay, fractures. Okay, there are a ton of different fractures that can and do occur, as you can see on the right side of this. These are all looking at the elbow. So fracture of the elbow. You have a supracondylar fracture where either the elbow is flexed or hyperextended and then they fall onto it. Okay. The olecranon process fracture is usually just falling on a flexed elbow, and I see those frequently in usually volleyball and basketball, when they're falling on that hard gym floor, and they land just right on that, and it ends up fracturing off. A radial head fracture, the mechanism of injury is a longitudinal compression, basically foosh. Remember, it means fall on outstretched hand. And or a forearm fracture, where it can be open or closed, simple or complex, and it depends on the degree of angulation or displacement. Okay, so the pictures all right here are showing more so the olecranon area. We have had several patients or student athletes who have fractured the radius and ulna, usually foosh, and depending on what their sport is, they can usually continue to play if it's casted and we have padding over it and they don't use it like a weapon. Okay, a couple more, and this one's specifically looking at fractures of the elbow. So with dislocations and fractures, we're not doing really too many special tests. Usually with that, you might do similar to with the lower leg, a squeeze test, but on their forearm. And if when you squeeze, there's crepitus and crunching, or it lights them up, it's pretty apparent that it's a fracture. Okay, just like the dislocation, it's pretty apparent it's not where it's supposed to be. So either of those, we're not doing any range of motion testing, we're not doing any special tests. We're splinting them, checking the CSM, and sending them to urgent care or ER. Okay, now we're getting into the sprains, specifically of the ligaments. We've heard at length probably of Tommy John's and ulnar collateral ligament. It's when they have an extreme overload in a valgus maneuver, and usually it happens with pitching, overhand pitching and throwing, because that's not necessarily a natural movement. And then a radiocollateral sprain is giving a varus force. So think of tennis, both when they're doing backhand and forearm. These are looking at ulnar collateral ligament sprains. Okay, so on this, I don't know if I would even want you guys doing this. Normally, I would just do a valgus and varus stress test. This is just putting it in a different plane and looking for a shear zone. It's probably something that you guys will learn more so at the next level, but for the most part, like I've said, valgus and varus. And then we also have a posterior lateral pivot shift test, where we're giving them a valgus stress while we're supinating their forearm. Okay, so epicondylitis. There's medial and lateral. You've probably heard lateral epicondyle, where you're having pain in the lateral aspect. Most people will call it tennis elbow. I know my mother-in-law had it for a brief time, and she's like, I don't even play tennis. How can I have tennis elbow? That's just one of the things, kind of like with turf toe, they affiliate that particular injury with a tennis athlete. Okay, and that's on the lateral aspect. If you have it on the medial aspect, you might hear it as little leaguer's elbow, or if they get that kind of numbness and tingling, neuropathy of the ulnar nerve. And that's just when you kind of either are hitting that nerve repeatedly, or if the muscles around it are swollen and are pushing on that nerve, causing that neuropathy distally for that patient. Okay. And then this is looking for a tennis elbow, and just basically palpating. You can palpate both medial and lateral epicondyles, find out where the pain is, and you can have them flex and extend or pronate and supinate and find out where the pain is. Okay. Couple more pathologies. So we've already gone over fractures, dislocations, sprains. Now we could have a strain of a tendon or a ligament, and specifically here, this one's talking about a distal biceps tendon rupture. So down at the elbow, not up at the shoulder, in the bicep. It's going to be very common for those weakened warriors, stereotypically those males that are over 40 years of age. And what happens is they forget that, they haven't been practicing a million hours a week, and they play a pickup game, or they're getting back into getting in shape and go too hard, too soon, too fast, and end up having a distal rupture at that elbow. So it can be complete or partial. A lot of times they're going to say they heard an audible pop, and most likely you're able to palpate it and feel a defect, meaning you're going to feel a divot. You might be able to have them, flex their muscle, and you might be able to see a divot in that aspect also. Okay, there's a hook test for the distal biceps tendon rupture, and what we're doing is, getting your index finger and trying to palpate the distal biceps tendon, and if and when you're palpating it's causing them pain, or you can't actually find that tendon, most likely there's a rupture. Okay. Different nerve pathology. So before, we've talked already that we've got an ulnar, radial, and median nerve. Down here, this is looking at distally what it affects. So that ulnar nerve, before, how I told you guys, when you hit your funny bone, it'll send a shock or tingling and numbness to your pinky and ring finger. So that's the ulnar nerve. The radial nerve is going to be more thumb, and then the median nerve is more the palm of the thumb, first, second, and third digits, and then on the back side of the second, third, and almost ring finger. Okay. We are worried a little bit about forearm compartment syndrome. Sometimes I've actually had a volleyball back row girl with this, just repeated use and having gone to all these camps and not giving it any type of rest. So it is something that we are worried about, and we need to be cognizant and educate our patients on each of these. Some more about the nerve pathology. You guys can go back and look at this. And then how are we going to examine this on the field? Okay. With all those different baseball compilations, we see the position of the arm. Sometimes they're able to move it. Sometimes they don't want to move it. Sometimes it's just hanging there and they're, kind of jogging off the side to the sidelines because they know it's not right. Okay. Sometimes they still have the adrenaline, and it can take them, to get back into where they can kind of sit down and maybe lose it after that fact. But on the field history, we're looking at what force was involved, the position of the arm, and then looking at, for inspection, we're looking equal and bilateral. If there's anything out of the ordinary, it's going to be pretty apparent. When we're palpating, we want to palpate bony integrity first, so the alignment of the elbow. So palpating the humerus, radius, and ulna, and then now getting to the collateral ligaments, assessing if they can actively or passively move it, and then the neurological test would be more the upper quarter screen that we'll get into when we meet. Okay, elbow dislocations, I've already told you guys what we're doing. Activate EMS. Make sure we're splinting them in the place or the position that we found them in. We will be working with our vacuum splints. Checking CSM, so circulation, sensation, motor. Ideally, we're checking that distally, and we want to make sure that there is no other injuries that are going on with this particular patient. Last slide, guys. Fractures. So just like with the dislocations, fractures, we still want to monitor CSM distally. We're also going to splint them and make sure we're treating them for shock. I know with wrestling, they are habitually trying to show each other their game film, or, oh, look at this. I'm like, hey, can you not show that video right now? I don't want them to going into shock. So make sure, keep them calm, cool, collected. If Mama Bear or Papa Bear comes down, try and keep them calm, cool, collected, because if one of those start freaking out, that can affect your patient, and then that's going to also affect their vitals and potentially kind of ruin the calmness of the situation. We're going to transport the athlete to, well, we aren't, EMS or parents are going to transport them to a medical facility for further evaluation and treatment. Most likely they are going to get an x-ray. That way they at least have something to compare before and after and determine if it's something that's going to require surgical intervention where they might need plates or pins or whatnot. Okay, so that's what I had for elbow. I wanted to get something out to you guys. I was going to do elbow, wrist, hand, fingers, but I thought that would be too much for the first time. I will open up the quiz, and feel free to shoot me an email or call me if you guys have any questions. Thanks, and have a good one.